Hello.
Hi, ma'am. Good evening.
Good evening.
Uh, Ma'am, I have made you the co-host, ma'am. You can share the screen and start the class, ma'am.
Yeah, okay. Hello, everybody. First of all, happy Diwali to all. And we're going to discuss gastrointestinal pathology in this class today. So, this is a part of our 90-day university Proff pre-final mastery program. And in this program, we're going to rapidly revise all the important topics, volatile facts, and all the high topics for the exam. In Auricle, as you know, we have recorded classes, live classes, practical sessions, exam modules, and hard copy books. Recorded classes are useful in terms of flexible learning so that each topic will be can be revised and all important questions are going to be covered. Live classes, important in-depth coverage of concepts and also facilitates interactive learning. Express exam modules cover syllabus in just 20 hours and all important exam questions, frequently asked questions and previous year questions are going to be covered. There is a one-to-one doubt clearing session and hard copy notes set are also available. We have a question bank with all levels of difficulties for Proff exams, NEET, PG, FMGE as well. Practical sessions are available which facilitate hands-on experience. These are the subscription plans which you can go to the website and look for more details. So in this class, we're going to discuss a few gastrointestinal pathology. Okay. So first of all, we'll start with a few case-based questions. Okay. We're going to discuss in detail a few case-based questions. And then we're also going to discuss a few short essay questions. And also finally, we'll wrap up with a few multiple choice questions. So the first long essay question which we're going to discuss is this case. So this is a case of a man with gradual weight loss, abdominal pain, anorexia. Anorexia is the feeling of not having any urge to eat is anorexia. The patient will not be feeling hungry. So that is what anorexia is. And we have vomiting on this patient and mass in the epigastric region. The patient also has positive occult blood in the stool. So positive occult blood in the stool means whenever a stool test is done, it is not going to be red in color. That is, there is no gross blood in the stool. But when we do a microscopic examination of the stool, we're going to see red blood cells. We're going to see red blood cells in the stool. So this is what is known as positive occult blood. Occult is nothing but microscopic, or occult means hidden. Okay, as the dictionary meaning, occult means hidden. That is, it's not going to be grossly seen, but when you are doing a microscopic test, you are going to see this. So this is known as occult blood. And also another thing, firm lymph node masses in the left supraclavicular as well as periumbilical nodules are present. So there are so many clues which you can see in this question. First, you can see that the patient has weight loss. Okay. Then abdominal pain, anorexia. So weight loss and anorexia is a very important symptom of carcinoma stomach. Any carcinoma, any tumor, there is going to be weight loss. Anorexia is present in carcinoma stomach. And also we are given that there is a mass in the epigastric region. So there is a mass. Mass in the epigastric region again suggests a carcinoma stomach. And then there is positive occult blood. So when do you have positive occult blood? When there is an ulcer. Okay, there are a few causes of positive occult blood. When there is an ulcer, what is going to happen? Complication of ulcer is bleeding. Okay, so when there is bleeding, you're going to have positive occult blood over here. And also there is a lymph node metastasis. So always think of, whenever a lymph node is involved, always think of a malignancy, because benign conditions are never going to cause a lymph node mass. So this diagnosis is carcinoma stomach. We have lots of clues here. Okay, and there is a specific name for supraclavicular lymph node metastasis with associated with gastric carcinoma, which we will be discussing. So here, this is a case of suspected gastric carcinoma. Okay. So we have been given that there were two lymph nodes. One is supraclavicular lymph node and the other one is periumbilical lymph node. So these two lymph nodes are named lymph nodes. There are a very few named lymph nodes. So these two lymph nodes both are associated with carcinoma stomach. Both are associated with gastric carcinoma, and both of them have specific names. So supraclavicular lymph node, which is associated with gastric carcinoma, is known as Vercos lymph nodes. Okay, and periumbilical lymph nodes associated with gastric carcinoma is known as Sister Mary Joseph lymph node. These are just the names of people who have discovered them. So they have been named accordingly. Sister Mary Joseph lymph nodes, periumbilical, and supraclavicular Vercos lymph node. So both of these are associated with gastric carcinoma. Okay. So this is, we know that the diagnosis. So the first question which is being asked is, what is the diagnosis? So how do you have to write the diagnosis? You have to write that this is a case of gastric carcinoma, and why is it gastric carcinoma? First of all, symptoms. Okay. And then second, we have lymph node metastasis, which is again suggestive of gastric carcinoma. So these are the clues. Now, the second question which has been asked in the log essay is etiopathogenesis of gastric carcinoma. Gastric carcinoma arises from the epithelial cell lining of the stomach. Okay, stomach has, I'll just give you an overview of the histology. So we can go back to histology and get an overview over here. So you will have epithelium. Okay. And then below the epithelium, this is also known as mucosa of the stomach. Okay. And you are going to have something which is known as a submucosa, which is below the mucosa. And then there is a small layer of smooth muscle, which is known as a muscularis mucosa. Okay, and then you are going to have a muscle layer, which is composed of muscles, smooth muscles only, but they're going to have layers of muscles. So in stomach, you're going to have 3 layers of muscle. In other parts of the gastrointestinal tract, what you're going to have is only 2 layers of muscle. So in the other parts of gastrointestinal tract, we're going to have 2 layers of muscle, and these 2 layers of muscle are transverse and longitudinal layers of muscle. Okay, but in the stomach, there is an additional layer of muscle which is circular. Okay, so there are 3 types of muscles which are present in the stomach. 3 layers which are going to be present, which will be helpful in contraction of food, and also which is going to be helpful in peristalsis. From the stomach, the food is ultimately going to go to the large intestine, like small intestine, and then it will go to the large intestine. So for that, this peristalsis is going to be helpful. So what are the risk factors for gastric carcinoma? This is a tumor which arises over here in the epithelium. So this is a tumor which arises in the epithelial region. So that is what it is. The risk factors include, first, there is a bacterial cause. And the bacterial cause is H. pylori. We'll be discussing more about how H. pylori causes gastric carcinoma, but for now remember bacterial cause H. pylori is an important cause. And the second one is smoking. Okay, and then there are nitrate-rich foods. Nitrate-rich foods is a risk factor. Okay. Chronic inflammation is also a risk factor. Chronic inflammation usually subsequent to atrophic gastritis. And then we have pernicious anemia, which is a risk factor which can also lead to atrophic gastritis. So what will happen when there is atrophic gastritis or when there is any condition which is leading to atrophic gastritis? This is going to cause something which is known as intestinal metaplasia. Okay. So metaplasia, as we know from our general pathology, means certain amount of the native tissue is getting converted into another tissue. Okay, because of some chronic inflammation or some chronic irritation. So this is what is known as intestinal metaplasia or metaplasia in general. One type of tissue is getting converted into another tissue. So in the stomach, we're going to have which are foveole. Okay, they are not going to have intestinal type tissue. So when these gastric type tissue is going to get converted into intestinal type tissue, so intestinal type tissue will have more mucins. So it's going to have increased mucin. So when this type of tissue is converted into intestinal type tissue, metaplasia, as we know, because of chronic irritation, we're going to have metaplasia. And metaplasia eventually can lead to carcinoma. This is from our general pathology, right? Whenever, for example, there is H. pylori infection and you're having intestinal metaplasia, we know that metaplasia as such is reversible. So when there is H. pylori infection producing chronic inflammation, you're going to have intestinal metaplasia. And once we are getting this H. pylori infection treated by antibiotics, what will happen is this metaplasia is going to reverse. Okay. But if this is not getting treated, there is chronic exposure, there might be intestinal metaplasia which can lead to gastric carcinoma. So this is one reason why H. pylori infection is going to lead to carcinomas also. Okay, so what are the risk factors? We have smoking, we have nitrate-rich food which can cause this, we have chronic inflammation by atrophic gastritis and H. pylori. Also remember pernicious anemia. Pernicious anemia is an autoimmune condition which leads to damage of parietal cells, which in turn leads to decreased vitamin B12. So this is what pernicious anemia is. Now, what they've asked is pathology. What is the pathology of this tumor? So grossly, this tumor may appear as an ulcerated mass with raised edges. So basically, there are grossly 4 types of tumors. 4 types. First one is exophytic. Exophytic, as the name says, exo means outward. So you're going to have outward projection of this tumor. So this is exophytic. Then second one is ulcerated. Ulcerated means there's going to be a crater-like appearance, which is ulceration. So this is ulcerated. And third thing is infiltrative. Infiltrative, as we discussed, we have mucosa, submucosa, muscle layer, and then the serosa. So these are the 4 types of layers which are present in any gastrointestinal tract. Okay, so this is going to be present. So when there is infiltrative, so it's going to get infiltrated into the muscle layer. Okay, and then combined type. Combined type is there's going to be exophytic as well as infiltrative, or ulceration can also be there. So these are the 4 types of pathology. So this is the gross pathology which we have discussed. So what is the 4 types of gross pathology? There's going to be exophytic appearance, which is outward projection, ulcerative appearance, which is a crater-like inward projection, and then infiltration into the submucosa or the muscle layer, and then you're going to have multiple things which is combined. So this is a Example of a gastric carcinoma, and this is an intestinal type of gastric carcinoma. Okay, there are two types of basically two major types of gastric carcinoma, which I am going to discuss. So this one is intestinal type. Okay, so this is an intestinal type of gastric carcinoma. You can see the glands here. It is infiltrating. It is going into. This doesn't look very good, right? Very hyperchromatic, and there is little bit of neutrophilic infiltrate necrosis also here. So this is what intestinal type of gastric carcinoma looks like. There's another type which is known as diffuse type of gastric carcinoma. Okay, this diffuse type of gastric carcinoma, you can see these cells are very single. They were not together, like gland form, not together. These cells are not single. These are all carcinomatous cells. These glands are all tumor glands, but you can see here that single cells are there. Okay. So these type of gastric carcinoma is known as a diffuse gastric carcinoma, and diffuse gastric carcinoma can be caused by a hereditary mutation also. The mutation is CDH1 mutation, which can lead to diffuse type of gastric carcinoma. The CDH1 type of mutation, CDH1 codes for a protein which is known as E-cadherin. This E-cadherin is what E-cadherin does is it is helpful in binding cells together. It is a cell adhesion molecule. Okay, so it is present in here and it is going to help to hold the cells together. So this is what E-cadherin actually does. But when this E-cadherin is somehow mutated because of a genetic condition, okay, because of CDH1 mutation, which can be genetic. So each cell is going to be separate because there's no E-cadherin to hold them together. Also, what will happen is these carcinomas are very aggressive and it is very easily metastasized because we know single cells, because these cells, these are also carcinoma cells, but these are together. There are no single cells here. When these cells, they have to split and become into single cells and go for metastasis. But these carcinomas are diffuse and singly scattered cells, so they can easily go to lymph nodes, go to blood vessels, and they can easily metastasize. So these are very aggressive type of tumor, and they are also easily metastasized. Diffuse type of gastric carcinoma associated with E-cadherin. Okay, diffuse single scattered, and also remember there are few signet ring cells over here. We know what signet ring cells are. Cells with a nucleus pushed towards one end and filled with mucin. So these are what signet ring cells are. So you will see signet ring cells also. Okay. So that is for gastric carcinoma. Now we are going to discuss second case. This is also a case of gastric carcinoma, but the question and these things are different. So we will just discuss it. This is a case of a 60-year-old male with upper abdominal pain, weight loss, and hematemesis. Now, same symptoms, upper abdominal pain is there, weight loss is there. Hematemesis is nothing but blood tinged when the person is vomiting. Okay, so when the person is vomiting, you have blood tinged vomit. So again, exophytic mass can lead to bleeding, and which is why we have hematemesis. Anorexia. Again, all classic symptoms of gastric carcinoma are there. Again, exophytic gastric carcinoma, we know diagnosis is exophytic gastric carcinoma. Why? Because they've clearly given there is an exophytic mass. Now you have to mention why do you say gastric carcinoma. So you have to mention the symptoms. Okay, anorexia is there, so there's a probability, and then hematemesis is there, and also which is also a symptom of gastric carcinoma. So what are the types of gastric carcinoma? You can see grossly. Types of appearances which you can see, exophytic as we already said. Okay, exophytic, outward protrusion of the mass, and then ulceration, infiltrative, and then combined. Okay, so these are the types which you can see. What are the pathogenesis? Again, we have discussed the pathogenesis, but I'll just quickly review it for you. First and foremost, most important, H. pylori infection. Why does H. pylori infection cause this gastric carcinoma? H. pylori infection leads to increased chronic inflammatory state, and finally it can lead to intestinal metaplasia, and because it can lead to intestinal metaplasia, which can further lead to gastric carcinoma. Okay, second one, nitrate rich food, chronic smoking. Okay, and then we have any chronic inflammatory condition causing atrophic gastritis. For example, one chronic inflammation, we know autoimmune gastritis, which can be caused by pernicious anemia also, because it is also an autoimmune condition. We already know that pernicious anemia was an autoimmune condition which was caused due to the destruction of parietal cells which was producing B12, and these parietal cells are going to get damaged. So we have an autoimmune destruction of parietal cells, decreased B12, also present, also autoimmune, also can cause atrophic gastritis, also can cause intestinal metaplasia, which can lead to gastric carcinoma. So these are the few causes which you have to remember for etiopathogenesis of gastric carcinoma. Now the morphology, and we have already discussed, the exophytic tumors usually are nodular masses that protrude into the gastric lumen. So we have discussed 4 layers of the stomach, right? Any gastrointestinal tract, you have to remember these 4 layers. From your normal histology, from your anatomy, there is a mucosa, there is a submucosa, there is a muscularis, and there is a serosa. So this is the lumen over here. So exophytic tumors usually protrude from the mucosa into the lumen. They may show ulceration and may have firm gray-white sections on cut surface. Histologically, we know the cells are pleomorphic with hyperchromatic nuclei and gland formation is there. So we also discussed there is an intestinal type and there is a diffuse type which has singly scattered cells. All right. So diffuse type we know has singly scattered cells. Why? Because it may also be associated with mutations in CDH1. CDH1 is responsible for the protein which is known as E-cadherin. The E-cadherin can hold cells together. So when they are singly scattered because of E-cadherin mutation, these are very aggressive and can be metastasized and also can spread by blood and lymphatics. So now the third question which you have been asked is the mode of spread. We know there are always, whenever you're being asked mode of spread, do not think twice, always remember 3 modes of spread. First mode of spread is direct. Direct mode of spread, direct extension. Okay, when there is a tumor here, it's going to spread directly to the adjacent organ. This is direct spread. By expansion, direct expansion. Second one, lymphatics. As we already discussed, 2 lymphatic spread, important nodes which you have to remember, supraclavicular Virchow's node and periumbilical system Mary Joseph nodes. Other nodes may also be involved, like around the celiac nodes can also be involved in gastric carcinoma. And the third one, hematogenous spread. Hematogenous spread to other organs. Okay, hematogenous spread to liver and peritoneal seeding also. So these are the modes of spread. Now we are going to discuss a short essay on H. pylori. H. pylori, remember, is a gram-negative bacterium. It is associated with chronic gastritis, peptic ulcers, and gastric carcinoma. We know the conditions which are associated with H. pylori. So what are the conditions? Chronic gastritis, peptic ulcers, gastric carcinoma. And apart from gastric epithelial carcinoma, H. pylori are also associated with marked lymphomas. Okay. Marked lymphomas are nothing but mucosa associated lymphoid tissue associated lymphomas. Okay, mucosa associated lymphoid tissue. These are a few lymphoid tissues which are present inside the stomach. So we have the few lymphoid tissue. These can get proliferated and become lymphomas because of chronic inflammation caused by H. pylori. So 4 conditions: chronic gastritis, which can lead to peptic ulcers, gastric carcinoma, and also lymphoma. So these are the 4 conditions which H. pylori can cause. Remember, it's a gram-negative bacteria. Okay. Potential carcinogenesis. Here, the small, slender things like this, which you can see right here. These are all H. pylori. Whenever a biopsy of a H. pylori infected individual is done, you can see these small bacteria, which are H. pylori. So now we are going to discuss the pathogenesis of this H. pylori. Okay. So first of all, we know what are the risk factors of gastric carcinoma, right? Environmental factors, we have already high nitrate-rich diet, smoking, mutagens, and all these things. H. pylori infection are going to produce 2 important virulence factors. These virulence factors are CAG-A and VAC-A. So what these virulence factors will do is they can induce inflammation. When they induce inflammation, we know lots of cytokines and lots of leukocytes will be produced. So what these will do is they are going to produce lots of free radicals and reactive oxygen species. Now these reactive oxygen species are going to get accumulated and they are going to accumulate lots of mutations. Now we know reactive oxygen species has the potential to damage DNA. Okay. And we also know that when DNA is continuously being damaged, it will undergo apoptosis. Because damaged DNA, if it gets replicated, then those mutations will get accumulated, right? So it will undergo apoptosis. What is essential for this apoptosis? Tumor suppressor genes are essential for this apoptosis. But when tumor suppressor gene is not there, it is not functioning properly, then this damaged DNA is going to replicate. When this damaged DNA replicates, it is going to accumulate these mutations, whatever mutations has occurred here. Accumulation of mutations. When these accumulate the mutations, this will eventually lead to carcinoma. Okay. So there are these inflammatory cytokines, transcription factors, temporary expression in gene, and finally epigenetic changes. That is what happens when continual DNA damage happens. There is going to be lot of changes and mutations which is happening. So when these keep on accumulating without undergoing apoptosis because of impaired function of tumor suppressor gene, then we are going to develop carcinoma. So this is the pathway of carcinogenesis. Ultimately, how does H. pylori cause infection? Cause carcinoma by producing reactive oxygen species. How? By inducing inflammation. Okay. And what are the 2 proteins which induce inflammation? You have to remember CAG-A and VAC-A. These are the 2 proteins which H. pylori produces and results in inflammation, which can produce reactive oxygen species, ultimately accumulating DNA damage and resulting in carcinoma. Okay. That is it. So morphology, this is again a short answer question. You can see how many times these questions have been asked. And based on that, you can actually predict how important this topic is. So typically, we know morphology of gastric carcinoma, we've already discussed. First of all, when we say morphology, you're going to write a few points about gastric carcinoma, discuss gross morphology. Okay, we have already seen what are the 4 important gross morphology features you have to discuss. We know that it is going to be exophatic, it is going to be ulcerative, it is going to be infiltrative, and then a combined combination of these. Okay. So microscopically, we know there is gland formation and abnormal gland formation infiltrating into the stomach and stoma. So this is our intestinal type. And the precursor of intestinal type is intestinal metaplasia. This also we have discussed. Okay. And then there's another diffuse type. What should you mention in diffuse type? We know that diffuse type, singly scattered tumor cells are going to be there. It's an aggressive type. We know why it is aggressive, because It can be caused by hereditary mutations in CDH1. Okay, and CDH1 we know E-cadherin. And what can this produce? It can produce signatory type cancers. So these are the two things: gross microscopic intestinal type and diffuse type. So this is the morphology of gastric cancer. Now, again, next short essay question which we are going to discuss is Meckel's diverticulum. Meckel's diverticulum is a congenital anomaly presenting as a true diverticulum. Okay, there are true diverticulum and false diverticulum. Whenever you say true diverticulum, it means you have to have all the layers to be. What is diverticulum? It is an outpouching of a tract. Okay, so you have intestinal tract over here, and suddenly there is an outpouching over here, and then it continues as normal. So this outpouching is what is known as a diverticulum. When you say true diverticulum, it means all four layers are going to be present in this pouch. Okay, so we know what are the layers. We know that there is an inner lumen, and beside the lumen there is mucosa, and then immediately you have submucosa, and then we have muscularis, and then we have serosa. So these are the four layers which are present. So when this diverticulum has all these four layers, then it is a true diverticulum. When it does not have all the few layers, it has only 3 or 2 layers, then it is a false diverticulum. So this is how we differentiate between a true diverticulum and a false diverticulum. Meckel's diverticulum here is a true diverticulum. In this image, you can see that all the layers are outpouched. So what is this Meckel's diverticulum? Why does it happen? With all layers of intestine, as we already know, it may contain ectopic gastric or pancreatic tissue. So where does this Meckel's diverticulum occur? It usually occurs in the small intestine. Okay. Small intestine usually have a different type of tissue. So it has a mucin-rich glands over here, and then it has a mucosa. But when you find gastric tissue in the intestine, or when you find pancreatic tissue in the intestine, then we call it as Meckel's diverticulum, provided there is outpouching. So in this outpouched area, you're going to see a few tissues which are made up of pancreatic or gastric tissue. So here you can see this is a normal intestine here, and then there are a few nests. These are pancreatic tissue. Okay, just remember Meckel's diverticulum is a true diverticulum, and it's going to have pancreatic tissue or gastric tissue in it. What are the complications? Complications are bleeding and hemorrhage. It can cause bleeding or lead to obstruction, ulceration, bleeding or obstruction, because see, there is an outpouching over here. So this can lead to obstruction, and then ultimately it will lead to ulceration also and bleeding also. So usually this is a congenital anomaly, so occurs in the pediatric age group. Okay. So now this is another short essay question which has been asked, which is Linitis plastica. Linitis plastica has a name. We can just decode the name. It means plastic or leather bottle appearance. Okay, not plastic, leather bottle appearance. Okay, this is an image of this leather bottle. So Linitis plastica is a diffuse, later very aggressive type of tumor. This is what Linitis plastica denotes a gross appearance. Okay, because you can see here, this is a leather bottle over here. Okay, this used to be used before for carrying water and all these things. So this is how the stomach starts looking. The stomach starts looking like a leather bottle. It becomes thickened and starts looking like this. So this is a diffuse type of carcinoma. So what does this denote? This denotes a gross appearance of the stomach. So this is what it denotes, resulting in thickened and rigid stomach walls. It's very thick and rigid stomach walls. All the rugae present in the stomach, they're going to be flattened and thickened. So this is what it is. Why does this happen? Due to diffuse infiltration by poorly cohesive cancer cells. So whenever there is a diffuse carcinoma, whenever you have a linitis plastica and when you take a biopsy or when you take a section and you see, you're going to find, most probably you're going to find diffuse type of gastric carcinoma with singly scattered tumor cells. Okay, so you can write the description of microscopically, you can see poorly cohesive, diffusely, poorly infiltrated cancer cells. So this is what linitis plastica is, and this is a gross appearance of aggressive diffuse type gastric cancer. And when you do a microscopy, what will you see? You will see poorly cohesive cancer cells, which shows diffuse infiltration in the stomach. Okay, whenever you have a whenever you have an ulcerated appearance or whenever you have an infiltrative appearance, it's going to involve only a single part of stomach. Okay, it's going to involve only one part of the stomach because that part is going to protrude and you're going to have cancer over there. You're going to have malignant glands over there. But since diffuse, poorly cohesive cancer can spread very easily, it is going to spread throughout the stomach. So that is why you have linitis plastica and thickened appearance in this condition. Now we are going to see another intestinal tumor, which is carcinoid tumor. Carcinoid tumor is a tumor which is of neuroendocrine glands arising from the enterochromaffin cells. What are enterochromaffin cells? In the stomach or even in the intestine, they have some neuroendocrine cells in the stomach or the intestine, which is known as enterochromaffin cells, and these produce a serotonin. Serotonin is the hormone which these produce. Now, serotonin, we know what is the function of serotonin. From our inflammation, you can remember we had histamine and we had serotonin which was produced during inflammation. And what was the role of these molecules? It was causing vasodilation. Okay, so during inflammation, these were the molecules which were produced to cause vasodilation. Correct. So now there is a tumor which is producing excess of serotonin. So what will be the what is going to be the symptom of carcinoid syndrome? Okay, so neuroendocrine tumor produces excess of tryptophan. Now lots of 5-HT. 5-HT is nothing but 5-hydroxytryptophan. 5-hydroxytryptophan is serotonin. Okay, so these are produced. And when this gets metabolized by monoamine oxidase, you have what is known as 5-hydroxyindole acetic acid. So this is one test. This 5-hydroxyindole acetic acid is the metabolite of 5-hydroxytryptophan. Okay. So this is going to be produced in the urine. So when you have to check if the patient is suffering from carcinoid syndrome or not, you can check for 5-hydroxyindole acetic acid in the urine. And indirectly, it reflects the presence of 5-hydroxytryptophan in the blood. So this is what happens. So since we know the serotonin is associated with vasodilation, we can see what are the symptoms: flushing because of vasodilation in the head and neck area, diarrhea, dyspnea, and also bronchospasm. From our inflammation, we remember that even from our inflammation, serotonin and they are bronchoconstrictors. So you have bronchospasm and diarrhea and flushing, which is associated with vasodilation. So what are the complications? Carcinoid syndrome can, first of all, carcinoid syndrome, usually this is the pathway, it starts in the intestine. Small intestine is the most common site of carcinoid. Can be gastric carcinoid are also common. Small intestine more than gastric carcinoids. Okay, so you have a carcinoid tumor over here which is going to produce 5-hydroxytryptophan. Now, first site of metastasis always from a carcinoid is the liver. This would go to the liver and metastasize. Okay, so this is going to go and metastasize. From the liver, it can go to the heart. From the portal circulation, you can actually go to the heart. So that is why carcinoid heart. And 5-hydroxytryptophan and this metabolites are also implicated in fibrosis. So you will also have fibrosis in carcinoid syndrome. Okay, so mesenteric fibrosis or fibrosis of the heart. So these symptoms are very common in carcinoid syndrome. So remember, carcinoid from the small intestine going to go to liver and then can go to the heart. What is the what is the diagnostic test which you can do? You can do a high hydroxy indolacetic acid in the urine. Okay. So now there are hormonally active carcinoids are known as carcinoid syndrome because when hormones are not produced in the blood, then it is just a carcinoid tumor. It can also be, it can be seen in your CT scan or it can be seen in your biopsy. But when hormone is produced, when there is excess of serotonin produced, then only you can see it in the urine. Now we'll see what you can see in histology in carcinoid syndrome. So first of all, you can see nest-like cells here. Always you will see these nests in carcinoid syndrome. Nest-like appearance. Now when we talk about individual cells, nest-like appearance as a whole, there are lots of tumor nests. When we are going to talk about individual cells, what we are going to see is salt and pepper appearance. What is salt and pepper appearance? You can see here there is a nucleus, right? There is a nucleus, and there are small dots, lots of small dots. So this is known as salt and pepper appearance. So these are small nucleoli which are very prominent. So this salt and pepper appearance is very characteristic. So first we will see tumor nests and we are going to see salt and pepper appearance. These are the characteristics of carcinoid tumor. So we know carcinoid tumor when it becomes hormonally active, it's going to cause carcinoid syndrome. Carcinoid syndrome will have all these symptoms which we discussed because if it's not hormonally active, it's going to be benign. No symptoms will be there. Okay, so mostly it can be an incidental finding also. Now let's discuss the last question. We're almost done with this lecture. We're going to discuss the last short essay question, which is acute appendicitis. Acute appendicitis is nothing but, see, appendicitis and acute. It's very easy. You just remember this and you can actually figure out most of the things. It's an acute infection of the appendix. Appendicitis inflammation. Okay, acute inflammation of the appendicitis usually caused by infection. Okay, it can also be characterized by inflammation due to obstruction. All right. So, what are the clinical findings you are going to see in this condition? Appendicitis is there. We know appendix is present in the right side of the right side of the intestine, right? Right side. If we can review, we can see that appendix is present in the right side. So you're going to have right iliac fossa pain in acute appendicitis. So right lower quadrant pain. Along with, if there is appendicitis, you're going to have fever, leukocytosis. Because it's an acute inflammation, you're going to have leukocytosis and acute. Acute inflammation, what are the inflammatory cells which are going to come into action? It is nothing but neutrophils. So neutrophilic infiltration is going to be seen. So this is a picture of acute appendicitis. You can see there is an exudate in the lumen. The mucosa is going to be ulcerated and then exudate, and then along with that you're going to see acute inflammatory cells, which is nothing but neutrophils in the lumen and as well as in the tissues. So this is what acute appendicitis is. First of all, what is acute? Write the definition. What is acute appendicitis? Write the clinical findings. What you will see: right lower quadrant pain, fever, leukocytosis. What are you going to see in histopathology? What are the causes? You can write what are the causes and what are the complications of acute appendicitis. So that is it for acute appendicitis. So this is the last essay question. Now we'll just move on and discuss a few MCQ questions. A 52-year-old man presents with a 3-month history of weight loss, epigastric pain, recent onset nausea. Physical examination reveals a palpable mass in the epigastric region. Endoscopy also shows a polypoidal mass in the gastric antrum. Which of the following is the most likely diagnosis? I think this question is the most easiest question. You have all the clues here. Weight loss, they have given epigastric pain, palpable mass, polypoidal mass. Whenever you see a mass, always think of carcinoma. Don't think twice. So this is gastric carcinoma. Next question. A 48-year-old man presents with epigastric pain that worsens at night and occasionally after meals. He also reports bloating and nausea. An endoscopy is performed revealing mucosal inflammation and an ulcer in the gastric antrum. So you have an ulcer in the gastric antrum. A biopsy is taken and histopathology confirms the presence of H. pylori. Okay, so they've given you have H. pylori infection. What is the question? Which of the following best describes the mechanism by which H. pylori contributes to the pathology? Okay, so there's an ulcer. What is the mechanism? So let's just read through the options and figure out. Increased production of hydrochloric acid leading to epithelial damage. Okay. Increased production of hydrochloric acid is not the primary reason for the production of ulcer by H. pylori. Stimulation of mucosal cell proliferation leading to gastric polyps. No, even this is not the primary. H. pylori can cause a few gastric polyps, but this is not the primary mechanism. Release of urease and cytotoxins that damage the epithelium and promote inflammation. Right, this is the answer because we saw that there are a few cytotoxins which are produced by produced by H. pylori, like we saw the CAC protein and VAC protein, and also remember urease is also produced by H. pylori. How does urease work? Why is urease very significant? We know that there is gastric acid. Okay, urease helps the bacteria to survive in such high pH. So that is why urease is an important enzyme, and it contributes to the pathogenesis of ulcers. Direct invasion, no. So answer is C here because it produces urease and cytotoxins that damage the gastric epithelium and promotes inflammation. Okay. Right. Remember urease also. There is a urease breath test which also can be done in H. pylori to detect the infection. So the next question, a 10-year-old boy presents with abdominal pain and signs of intestinal obstruction. Imaging shows a diverticulum. So this is Meckel's diverticulum, right? So what is the most common complication? We know the most common complication is bleeding due to ectopic gastric mucosa. Most common complication of Meckel's diverticulum is bleeding. And remember, it is present in the anti-mesenteric border of the small intestine. And then the next question is 65-year-old woman has small bowel carcinoid tumor. So they've given that small bowel carcinoid is there despite being asymptomatic. Her oncologist suggests a follow-up test. Which test is most appropriate to monitor? So you know we have already discussed it is 5-HIAA, which is a metabolite of serotonin. So that is the test which is used. Okay, so that is all for today's class. Thank you very much.